regarding chest X-ray. So we have got 5 teams from different colleges. So I think this will be more of an interactive session of 45 minutes duration. So why do you want to know about a chest X-ray as anesthesia postgraduates? First and foremost thing is to face your exams. To pass, you should have a basic knowledge of exams. Without a basic knowledge of chest X-ray, you cannot appear for a practical exams in anesthesia. Not only for the X-ray session, but the clinical sessions, discussions are all, many of them are based around the clinical discussion of chest X-rays. Then before interpreting a chest X-ray, you should know why I ask for a chest X-ray. What is this X-ray for? For example, a child with a foreign body in the bronchus and a preoperative chest X-ray of a routine patient and an elderly patient, we look in different angles. So we should know why we are looking at the chest X-rays. What are the indications? So, what are common indications of chest X-ray in anesthesia and critical care practice? Can some of the postgraduates sitting and postgraduates sitting behind also can volunteer? Yeah, please, Anju. Yeah. Anybody can, please. We'll not waste much time.
It is used as a pre-anesthetic workup in patients with known cardiorespiratory diseases. It is used for follow-up and management in following any event like chest trauma or in order to see for any foreign body insertion following an event for follow-up and management. Then it can be taken up in patients more than, chest X-ray can be taken in patients more than 65 years of age for pre-anesthetic workup.
As a part of pre-anesthetic evaluation, patient, even a child with a known cardiopulmonary disease should have a chest X-ray, but not as a routine for all the patients who does not have a patient as a grade 1 patient coming for a inguinal hernia repair of 21 years need not have a chest X-ray. So it's harmful for the patient. So like that, and in critical care, you have to take X-rays. Maybe you have to take daily X-rays, or in the operation theatre, when a major event occurs, you may have to go for a chest X-ray, and we'll go one by one. Okay. Medical College Kottayam, just put out your hands. Yeah. Please tell me which are the common views of chest X-ray. Commonest view of chest X-ray taken is?
PA view.
PA view. Why do you take a PA view commonly?
Scapula are away from the lung fields, so the lung fields can be more visible, and the heart shadow doesn't look bigger.
Which are the other views taken?
AP view.
AP view is taken. What are the indications for AP view?
In patients who can't stay.
Mainly patient who cannot cooperate for a
PA view.
PA view, who cannot stand up, who cannot take a deep inspiration. All those patients who are bedridden, who cannot cooperate, in ICU patients, in children who cannot cooperate. Those are, and there are specific indications. Then the other views taken are lateral views for assessing the any space occupying lesion to assess. Now we have got CT scan and all to know those things, to know the retrosternal airspace. So many, then oblique views and all other views are there. So this is how a chest X-ray is commonly taken. The patient stands in full inspiration and the beam comes from 6 feet from the back. When in an AP view is taken with the patient lying down with the film down and the beam coming above. So next team, just so I have displayed the PA view and an AP view. The PA view is the commonly taken view. Just next team is from
renal medicine.
Yeah. Please compare these two X-rays.
First is PA view. Here the scapula.
That's the commonest taken view. Is PA view. Yeah.
Here the scapula will be out of the lung field. Clavicles also project out from the lung fields, and we can the cardiac shadow will be less prominent in PA view. For AP view, we
You can see, comparing these two films, you can see there is an apparent cardiomegaly seen if it's interpreted in a AP view. So never comment upon the cardiac shadow or cardiomegaly in an AP view. Always ask for a PA view. And in an AP view, it is taken in full inspiration. You can see the heart shadows, the lung shadows are very compressed and all. So whenever you comment upon the chest X-ray, you should know which view is that, and then comes to the lateral view. Lateral view is taken in certain situations when the patient is standing. I'm not going to details. For example, in COPD patients with retrosternal air space and all, to delineate mass lesions, we take a lateral view. So, what are the prerequisites of reading a normal reading a chest X-ray? What are of the film? Yeah, Mushina. Yeah, please tell. Calicut Medical College. Yeah.
Patient details has to be noted.
Louder or
Patient details has to be noted, and the clinical.
Yeah, first of all, the clinical details. Why the X-ray has to be taken has to be noted. Then the clinical details has to be known. Yeah.
Then the label, right or left, has.
Yeah, labeling. Dextrocardia with the situs inversus patient, you just put it on the reverse. It will look like a normal X-ray. I had my own relative accidentally came for an appendicectomy and was accidentally found to have this condition, and we again rechecked in the lab whether the X-ray was taken, was it wrongly labeled, then only we diagnosed. So it exactly replicates. So always see and confirm the labeling whether it is right or left. Here you can see the first film, it has a aortic arch is on the opposite side, the other is at the dextrocardia. So looking at the gastric air bubble and the cardiac apex, you can know whether it is a properly labeled also. Yeah. Then
look for male or female.
Yeah, male or female. The breast tissue, soft tissues. Yeah. Then approximate age, child, neonate, adult, old age, you can make out. Then
look for the exposure of the film.
The exposure should be proper. It should be neither underexposed nor overexposed for a proper interpretation. So in an underexposed film will be like like a pale film, white film, while an overexposed film will be a dark film. So you cannot delineate the structures. So you have to have a properly exposed the film, and neither underexposed or overexposed. Then very important thing is positioning. The patient should not be in a rotated or an angulated position. So it will affect the lung shadows. It may apparently look like a pneumothorax or other thing, or the clavicles. To know the exact positioning, one should draw a line from the center point from the spinous process and measure the distance to the medial end of the clavicle. So in a properly positioned film, so before interpreting the X-ray, you should make sure these things are satisfied. Then normally the chest X-ray is taken in full inspiration. A patient who cannot cooperate, who cannot who is not taking the full breath, you may interpret in a wrong way. So or in certain situations you may need an X-ray expiration film, which otherwise normally it should be taken in full inspiration. In a full inspiration, you can see 6 pairs of ribs seen anteriorly and 9 pairs above the diaphragm. Then regarding the radio opacity, the different tissues has got different radio opacities. So the denser tissues like bone, you can see here in the film, the bones, the lungs are darker because of the air. And the metals, you can see a tracheostomy tube here, metallic, white, soft tissues. So the different tissues has got different radio opacities. So you should know all these things before interpreting. So you are from Lisi Hospital. So this can, and now many candidates are appear for DNB also. No, DNB candidate, DNB. These sorts of OSCEs are commonly put up for exams. With a chest X-ray, they give a clinical details for exams. So with this chest X-ray, the clinical details is 35-year-old male. He was on postoperative elective ventilation, and he suddenly developed tachycardia, hypotension, and asymmetric chest expansion. So the questions are: what is the spot diagnosis? What are the clinical features? What are the predisposing factors? What are the managements? So these sorts of OSCEs are very common in DNB exams. So can you answer these things? Yeah. And one important clue is whenever you see a chest X-ray with these sorts of ECG leads and all, never endotracheal tubes, never say it is PAVU. No patients in ICU can stand up and take an APU. So before, when you see an ECG lead, no patient will go to the X-ray room with an ECG lead and endotracheal tube walking. So that's a first. Okay, please go on. Pneumothorax, when you say pneumothorax, it should be right or left? Or so it's a right-sided pneumothorax. In pneumothorax is the presence of air in the pleural space, sudden fall in oxygen saturation. So for Viva and all these questions, this can be given and you can be asked about everything about pneumothorax, how do you distinguish, or ICU management or whatever it is, depending upon the whims and fancies of the examiner. Or your slip of tongue may stimulate the examiner to ask to a different angle. Suppose you would say it's a normal X-ray, something like that. Or also not a properly rotated film can also mimic these sorts of pictures. So before interpreting as pneumothorax, always make sure that the lung shadows are seen in the opposite side, the mediastinal shift is there, there are no lung markings and vascular markings are there. So all these sorts should be made. So you are from which college?
MBS Medical College.
Yeah, hosting college. Okay. So these are two films. Can you just of the same patient after at different occasions?
Yes.
So this shows an importance of serial film. Can you make a guess?
Yes. In the first X-ray, it's a PA view of a male patient.
It can be one can be underexposed and there can be an overexposed. That is one diagnosis. And other thing,
and the
you see the lung markings, the lung shadows, lungs are plethoric.
In the first.
Yeah, suppose the patient after a TURP surgery has disorientation, this thing, restlessness, you take a chest X-ray, this was the X-ray, and the patient later develop pulmonary edema and all, the patient is put on ventilator, then evening you take a repeat X-ray, it becomes clear. So that means the patient has improved. Or after dialysis, a patient has a pre-dialysis patient. So these sort of patients, so you have to compare with the older films, or after therapeutic intervention, after dialysis, after ventilator therapy, it clears like this. So this is the importance of comparing with the previous films. Always compare when an older film, when they have a mass lesion, the growth of the lesion or something else, and also compare with the other radiological features, investigations like CT scan and all, if available. Okay. Now this is a importance of taking a serial films. This is a the first film is a preoperative, just a screening film for a patient who was posed for a neurosurgical procedure of the spine and apparently normal. So the patient was had an internal jugular IJV cannulation done, and after some time the airway pressure went high, and the surgery was cancer patient was taken back to the ICU, and chest X-ray was taken, and it showed a massive right hemothorax because of this therapeutic intervention. It can happen. This is a real film which occurred in my operation theatres, and the patient was later put in an ICD drain, and after 2 days, the next day, the picture you can see after ICD insertion is getting cleared off, and after 1 week on discharge from the ICU, the patient's bilateral lungs are getting important. So after an event, when you have in the operation theatres or after any therapeutic intervention, there is any gross change in airway pressures or anything like that, you may have to go for chest X-ray, and follow-up X-rays should be taken for comparison and for the patient follow-up also. So coming all those things, so there are, how do you approach a chest X-ray systematically? You are from which college? First batch? What, Lakeshore?
Lakeshore, VPS
Lakeshore, yeah. So in an examination, when you are given a chest X-ray without any clinical details, just go, either you can, if you are so confident, you can just again tell the diagnosis, systemic hypertension, or a patient with a gross cardiomegaly, or a pericardial effusion, you can rise this up. Or if you don't jump into the conclusion immediately, just wait for take one breath and just see what is happening, what is the X-ray, and go through the, if no clinical details, in any way you can go, at your own, either it can go by the clinical details, either you can go for a organ wise, or you can go from inside to outside, or from outside to inside, but whichever way. But the importance is we should, and when you find any abnormalities, or for example if there is a rib fracture in a chest X-ray, so look for whether there is any associated lung contusion, lung injury, hemothorax, pneumothorax, or a subcutaneous emphysema, associated mediastinal shift. So in that way you should go associated things. So so whichever approach you go, the important thing is you should not miss the important findings. Okay, so this is one. As an anesthesiologist, we recommend to we always consider the airway. Can go for the trachea first. Before commenting upon the trachea, one should ensure that the film is properly positioned.
Any rotation is there?
Yeah, otherwise the trachea will show apparently shifted. Look for any tracheal narrowing, tracheal shifting, tracheal compression, all those things, and you can do whichever way. And associated the abdomen, the other organs also you may have to look for example air under the diaphragm, or an elevated hemidiaphragm with a huge tumor in the abdomen, or a pushed hemidiaphragm with a mass lesion in the lungs. Such things also you should come across. So this is the thing I told about the trachea and carinal angle, bronchovascular markings, all those things. So just can you make out compare these two X-rays and tell me the diagnosis, focusing on the trachea?
In the first X-ray, it's look normal. The second X-ray, it shows the tracheal region. There is a narrowing of the trachea.
Yeah, you can see the trachea. Air
Airway.
is darker.
Air
shadow is there. So it can be a spotter. It can be what are different diagnoses? What are the commonest diagnosis?
Tracheal stenosis.
Tracheal stenosis is the commonest thing with the trachea. Can it be a tumor? Goiter, thyroid.
Thyroid goiter.
Could be an enlarged thyroid.
Enlarged thyroid, or any other
Mediastinal masses.
or other cysts. Yeah. And if you have any doubt, you can go for a lateral
view.
This can be a spotter. Yeah. So I'll go by organ wise. So as an anesthesiologist, I go with the important the trachea, air shadows, then cardiac shadows. The examiners, in examination as well as the clinical scenarios, the cardiac shadow we should be very, and we should correlate, or you should with the clinical finding. For example, if a patient is having a long-standing hypertension, or you look for a cardiomegaly. If a patient is having a mitral stenosis, you look for features of the mitral stenosis. So you should know. And examiners are fond of so many questions in cardiac shadow. What are the normal right constituents of right heart border of the heart, left border of the heart? Which are structures which are not seen in such views, in these views, all those things. So, never comment upon when it is a AP view. Always make sure that the film is a PA view, it is properly positioned. And what do you mean by cardiac Silhouette? Silhouette is the sharp border of the cardiac border is normally called as cardiac. Can you mention some condition where the Silhouette is what is Silhouette sign?
Any intrathoracic structure opacity which is in contact with the heart, the aorta or the diaphragm, may obscure the normal border of the heart.
Anything which obscure the normal sharp contour of a anatomical structure by a pathological structures like a tumor or something else, it is when it is blurred we call it a Silhouette sign. So the cardiac Silhouette should be very sharp and delineated, and look for the position, the size, the borders, any chamber enlargements. Normally the left atrium and the right ventricle are not normally visible in a PA film. So you should know the structures which constitutes the borders of the heart. This is the PA view. Yeah. So the right border is constituted by, please.
Right border of the heart is formed by
from above downwards it is?
From above downwards.
While exam it is better to tell from above downwards. Okay.
From above downwards, the right border is formed by superior vena cava, right atrium and inferior vena cava. And the left border of the heart is formed by aortic arch, main pulmonary artery, left atrial appendage and left ventricle.
Yeah, in old age or atherosclerotic you can have an unfolding of aortic arch. In a mitral stenosis the concavity of the left border can become straightened or even bulged out. The left ventricle can be enlarged or shifted in hypertension. The right border you may have shadow in mitral stenosis. So all these then ventricular aneurysms you can see if they are in left border sometimes. So you should look at the heart borders in a systematic way to find out the clinical details, the abnormalities if any. So this is a common exam question. What are the features of left atrial enlargement? Left atrial enlargement is seen in
Mitral
stenosis.
Commonly, or other than mitral stenosis? Anything else?
Left atrial myxomas.
Huge left atrial myxomas. Yeah, okay. So the commonest. So you can see the, what is
mitral
prosthetic
mitral valve.
Metallic prosthetic mitral valve is there. These
Double density sign.
arrows are showing the double densities or the shadow in shadow, which is due to the enlarged left atrium seen in the heart border. So this so the left atrium can enlarge upwards, downwards, sideways. The carinal angle can be widened. Special X-rays is barium solo X-rays can be taken to delineate these features which are not taken. So this is a very common clinical as well as the exam oriented question. What are the features of left atrial enlargement in chest X-ray? PA view. One should be able to, the answer should be at your fingertips. So what's the importance of cardiothoracic ratio?
Normally the cardiothoracic ratio,
Mic close.
cardiothoracic ratio measured in the PA view, it should be less than 0.5.
What is cardiothoracic ratio?
The cardiac, the widest.
Again, it should be measured only in a PA film. Never PA film. You draw a vertical line from the midline in a properly positioned film.
Right heart
and
border.
the A is the
Towards the right heart line is drawn
towards the right heart border, the maximum line, and B is the
left heart border.
to the left border, and A plus B should be
Less
50% or less than the total C in a normal. If there is cardiomegaly or in an apparent film, you take a PA film, AP view, it will be always, so don't tell cardiomegaly. So make sure the patient is, and which are the conditions where you get, next group, which are the conditions where you get the cardiothoracic ratio and enlarged?
Left atrial enlargement.
Left atrial
Left ventricular enlargement.
Okay, these are three films showing the cardiothoracic ratio measurement. So this is the central point, and this is A, this is B. This is apparently a normal film. Here you see a grossly enlarged heart. Probably this is not a left ventricular type. It's a biventricular enlargement. Can be due to any cardiac disease, cardiomyopathy, or improperly positioned film also can have such a picture. And you can see the difference of these two. This is also cardiomegaly. The CT ratio is high. Can you make out the difference between these second and third films? Pardon? Huh? Yeah. Which one? In which film? Third, second, or third? Third one. Borders are more sharp. Yeah, right. Here also border is sharp. Here the right side border is not sharp. Here it is sharp all round, everywhere. It is somewhat like a balloon filled with water. So it looks like more of a pericardial effusion. So it is say ballooned out heart. Most likely pericardial effusion. So this is the importance of cardiac shadows, cardiothoracic ratios, cardiac borders, and all. And this is a film of Tetralogy of Fallot. You can say heard of boot-shaped heart and all. Sometimes these films can be given as a spotter for your exams, or you can be asked in your clinical viva and all what are features. This is a boot-shaped heart is seen in Tetralogy of Fallot. You can see the pulmonary oligemia with the cardiac borders, concavity of the left cardiac border, decreased pulmonary. In which conditions you get pulmonary plethora?
In ASD or
in congenital heart disease?
In ASD or
yeah, ASD, VSD, PD and all, you may have pulmonary plethora. Okay, so these are the, I am just rushing through my important features. So I was just now going to the cardiac heart and heart borders. I'm just going through the important points only. Now I am going into the hilum. Hilum, the left hilum is normally 1 to 2 centimeter higher because what is the reason for that?
Left pulmonary artery is higher.
Yeah. So look for hilar shadows. Which are the common hilar shadows? Normally, are there any hilar shadows normally seen or not? Are these shadows normal or not? These hilar shadows. Normally, there are no hilar. It should be clear. Only pathological or some look for any lymph nodes, tumors, or all those things in the hilar shadows. Whether in the hilum. Because hilar lymph nodes can enlarge in so many pathological conditions, which can have anesthetic implications also. They can come, or the examiner may ask to do. You want to do a thoracoscopic biopsy. What is anesthetic management with a hilar shadow? Or the patient can come with a prostate for a prostate surgery. They may have multiple cannonball metastasis in the lung fields. So such things you should look forward. So hilar shadows, unilateral, bilateral shadows. There are so many differential conditions. I am not going into details. It can be tuberculosis, tumors, vascular, sarcoidosis infections, and all those things. And if there are any mass lesions seen, always go for a lateral view or a CT scan. So then go for mediastinum. Mediastinum can be assessed as the upper, middle, and lower parts. And to know, you may have to have, if there are any lesions, you may have to take a lateral view. And the aortic arch is the first structure on the left, followed by left pulmonary artery. And I'm not going. There may be mediastinal shift due to structures which push and pull, like pneumothorax, effusion, collapse, and all those things. Then widening of the mediastinum may be seen in mass lesions or rupture of major vessels, blood vessels. For explanation's sake, the mediastinum in a lateral film can be taken as anterior, middle, and posterior, and these are the various types of lesions which are seen in the mediastinum. It can be lesions, fluid, fat, or vascular, and depending upon the clinical details, we have to diagnose or these conditions. So these two films you can see. This is the normal hilar. Hilum is seen both sides. Here you can see the bilateral hilar pulling up because of the lung pathologies. Tuberculosis like diseases can have collapse and all those things. So this is bilaterally pulled up lung hilum when compared to the normally placed hilar shadows. Here also you can see pneumothorax with the medium. You can see the lung shadows, bronchovascular markings in these areas. Here you see it can be an encysted pneumothorax or a bullae or a cyst or something. You cannot see these are the different diagnoses. The lung markings are not there. There is push of the heart and mediastinum towards the other side, opposite side. So these sorts of pictures can be seen in pneumothorax or lung cyst, bullae, or a normal patient intraoperatively has sudden fall in saturation, high airway pressure. You take a chest X-ray, these sort of films may come, and it may be a pre-existing bullae can rupture and produce such sort of features. So next coming to the mediastinum, however the hilum, cardiac shadows, trachea, cardiac shadows, hilum, mediastinum. Then I am coming to the lungs. So while interpreting the lungs, always compare both lungs in a systematic way, upper, middle, and lower zones, and episodes down. Compare the right and left, and always ensure it is a properly positioned film, properly exposed film, and it is a not rotated film. Otherwise, you may have a apparent feeling of a pneumothorax or something like that. And look in a systematic way. And what is an air bronchogram? Please, what do you mean by air bronchogram?
In a consolidated area of the lungs, there will be prominence of the provenance of the small bronchi.
Yeah, air is seen as
air is
seen as darker shadows.
Darker shadows clearly visualized in
yeah,
consolidated
yeah.
areas.
Look for any air bronchogram, opacification, lung pathological, any tumors, cyst, and always go in a systematic way. And if there are any lesion, you may again have to have a lateral view for delineation. So the lung fields are evaluated as upper, middle, and lower. This for just for explain sake only, and always compare with the both sides, and look for symmetry, vascularity, mass lesions, nodules, etc., etc. So this is a typical PA and a lateral view of a. Please explain this. Yeah. 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 Even in deep inspiration, this much is not seen. So this is a hyperinflated lung, and you can see the the lung shadows are hyperinflated. You can see more ribs. The diaphragms are pushed down. The lung is this is called a tubular heart are all, and in the lateral view you see the increased air spaces. These are all due to air trapping. So these are all typical features. This can be a spotter, OSCE, exam questions, clinical case discussion, whichever way. You should be thorough with these X-rays, COPDs. Can next batch can you identify or make a spotter of this? Make it a little difficult. Two different X-rays. Look at the lung fields. I am giving a clue of first one.
First one looks like.
Can you see? Can you make out some lines? There should be some imagination also. You can see bilaterally. You can see thin lines which are not there in any normal. It is not a bronchoscopy markers or anything. So if a patient comes, with these sort of films for a thyroid surgery, for example, what anesthetic implication does it have? The examiner asks. This can be lung cyst, congenital lung cyst, emphysematous cyst. So in such cases, this lung cyst during under anesthesia, they can with hyperinflation can rupture and produce pneumothorax, or with your nitrous oxide it can get enlarged.
Spontaneous pneumothorax.
Yeah, so this. What about this second X-ray?
Honeycombing can be seen.
Pardon?
Honeycombing can be seen.
Yeah,
It looks like bronchiectasis.
Yeah, bilateral. Yeah, most likely to be
bronchiectasis.
Yeah, you can see honeycombing like bilateral bronchiectasis. This patient can come for, or this may be the picture of a patient posted for a lobectomy. So you may examiner may ask everything about PFT and all those things which we had discussions. So these are in lung fields. These sort of things you may come across. Okay. So this is miliary tuberculosis. You can see the difference between the cannonball metastasis and these are all bilateral homogeneous opacities in the bilateral in lung fields. This is miliary tuberculosis. You can see catagonium dot like in bilateral lung shadows, whereas these are all metastatic lesions. Patient may have remote thyroid, breast, or prostate cancers. So these sorts of things may be an accidental finding when a patient may during a routine chest X-ray, or a patient may not have any symptoms coming for a hernia surgery. A patient might have had a thyroid, prostate cancer, and may come with like this. So you should know you should look at all these things. Can be examined. Then atelectasis, lung atelectasis can have push and pull and all those things. I am not going to much details because of lack of time. Then consolidation, you can see air bronchograms, the opacities, and whenever you see such lesions, you can have better delineate with a lateral view also. So this is a favorite slides of examiners, and I think more than a dozen of exams I have given these slides for diagnosis. So mitocinosis, all the features, the cardiopulmonary features are there. The lungs are plethoric, maybe due to the pulmonary plethoric edema. The left heart border is bulged out, and the shadow in shadow, the splayed splaying of carinal angle, all these features are features of mitral stenosis, and depending upon the severity and duration of mitral stenosis, it can vary, and after treatment all the features may not come back or revert to normal. It may exist to the lung shadows will come to almost normal, but the heart shadows may not come to, and examiners are always fond of asking this curly A, curly B, curly C signs, which nobody has seen practically. I have never seen it, but every examiner is very fond of asking this curly lines. So for exam purpose at least know what is curly lines whenever there's in pulmonary edema. These are all horizontal lymphatic channels seen. Curly A, B, C lines are all there. So before doing exams. Okay. In congestive cardiac failure, here you can see bilateral opacities basilic with minimal effusions. So this is myone pneumonics, ABCDE for congestive heart failure. They may alveolar edema, curly B lines, cardiomegaly, if there is associated cardiac lesions, then dilated upper lobe vessels, pleural effusions. So these are all features of congestive failure, and when a patient is ventilated or with diuretics, the patient can these pictures can revert in within hours. So you should have serial pictures and all, or to know the prognosis also. Then comes ARDS. How do you differentiate ARDS and chest and pulmonary edema, acute pulmonary edema? Yeah.
In ARDS patient, there will be no cardiomegaly or pleural effusion. But in congestive heart failure patients, there will be features of pulmonary edema, cardiomegaly, pleural effusion.
Look the history of the patient. Pulmonary edema patient may have either a underlying cardiac disease like mitral stenosis, or an renal failure patient not dialyzed, or a patient with overloaded fluid therapy. Such clinical history, and it has got better prognosis. But the ARDS patient has another type of history with a prolonged surgery, having multiple trauma patient in ICU for so many days. Which one has better prognosis? Which is better to treat?
Pulmonary edema.
Pulmonary edema is better to treat.
Better prognosis.
Better prognosis. And the other thing, you have to treat the underlying cause, and it may have a prolonged. So, and the features the lung features may overlap each other. But the typical picture described in acute pulmonary edema is the bat wing or the reverse mustache sign, something like that it's called. Mainly because it is of the shadows are in the hilar region, but here it is uniformly distributed. Here you can see there is tracheal tube, this tracheostomy tube, the bilateral motile shadows, all those things. So preceded by major events, there is no cardiomegaly, all those things. So the clinical features as well as, and some features can coexist. Some ARDS patient can have pulmonary edema, but the reverse also is possible. So after coming from the lung fields, next I go for the diaphragm. There is no rule that you should go this way. This is my own way which I have adapted in describing. That's all. So diaphragm, look at the normally which diaphragm is higher? Right diaphragm, because
of the liver will.
So yeah, whenever you see a diaphragmatic lesion, you look there may be it can be a flattened diaphragm, as in COPD I told. Then elevated hemidiaphragm, or the diaphragm can be pushed up or pushed down. So many reasons. Then air under the diaphragm with some viscous perforated viscous. So all these things should be made out in the diaphragm. So the causes of elevated hemidiaphragm. This is you can see elevated hemidiaphragm here. Is it not? So it can be the decrease, because of decreased lung volume can be elevated, or a push from the abdomen, or the diaphragm zone, the phrenicular palsy. So it can have paradoxical movement and all those things. So look at the diaphragm, and this is a apparently elevated hemidiaphragm. So here you can see this is a diaphragmatic hernia, congenital diaphragmatic hernia. The examiner can ask anything about pediatric anesthesia or whatever it is. But this is an adult with, can see a traumatic, an adult with a diaphragm intestinal loops. You can see here through the ruptured diaphragm. So these are all diaphragmatic this thing. Now look for the cardiophrenic and costophrenic angles. Normally these should be sharp, and when there are effusions, fluid collections, blood, or this thing, it becomes obliterated and opaque. A minimum of 100 ml fluid is needed to blunt the costophrenic angle, and larger amount produce concave angle upwards. It's called Ellis curve. Yeah. And after aspiration, if air enters, it can cause hydropneumothorax with a horizontal fluid level. So it can be a horizontal fluid level hydropneumothorax. So these are, you can see, compare. Next, three films are there with blunted cardiophrenic and costophrenic angles.
First is a chest radiograph, AP view showing left-sided blunted costophrenic and cardiophrenic angle, suggestive of left pleural effusion. Second is a chest radiograph, posterior-anterior view showing right-sided air fluid level, suggestive of hydropneumothorax.
This is bilateral, like
bilateral. Third is bilateral.
Because of the time is getting over, I'll just make a quick. This is a massive pleural effusion or a post-pneumonectomy, massive whiteout of the whole lung. Post-pneumonectomy or a massive pleural effusion can have like similar pictures. So now I come to the skin and soft tissues. So in the skin and soft tissues, look for nipple shadows, breast shadows. A patient might have had a mastectomy, or patient might have a trauma with a subcutaneous emphysema. Look for lymph nodes, or sometimes the nipple shadows can be misinterpreted as mass lesion. So soft tissues and pathological things, you should look at it. Then bony cage, look for the contour, mineralization, lytic lesions, fractured ribs, sclerotic lesions. Then the rib cage, scoliosis, pectex excavatum, carinatum, all those chest abnormalities. Then I told the rib fracture. This is a AP film. You can see the films and all those things, the multiple rib fractures, lung contusions, and all those things. Now I just finished almost all those things. Then we take X-rays to when the patient to delineate foreign bodies, an aspirated tooth. After anesthesia, you may have to take a chest X-ray or this thing, or a child with a foreign body like coins, you may have to take a lateral view. So these are other indications for X-rays. Then our therapeutic indications to know the position of endotracheal tube, whether it is properly positioned. So here you can, or the patient has gone endobronchial. Here you can see an endobronchial intubation with a collapse of the lungs. So such cases, to know the position, you want to push or pull the endotracheal tube to position the therapeutic devices. You take a chest X-ray in the ICU and critical care. And after central venous cannulation, sometimes you may have any doubt and all. To know the position of the central venous catheter tip, it has got a radiopaque line. So to know the position or abnormal migration or the tip has broken, something like that, you may have to take a chest X-ray. Here you can, this is a catheter tip, central venous catheter tip. So the therapeutic devices, these are all X-rays which we take during our practice, anesthesia and critical care practice. So this is a
pacemaker
device, pacemaker devices, all those things. So Silhouette sign I have explained. So you can see this is the cardiac shadows is blurred here due to some other features. This is called the Silhouette sign. So in such cases, here also you can see this. So the vision, by pathological features, the sharp borders are delineated. We call it Silhouette sign, and you may have to further investigate, evaluate to find out what it is. So to come out, to conclude, I will just give a few spotter slides. Can you just please, Lakeshore Hospital, is it not? Lakeshore, no? Lakeshore female candidate, please. Yeah. Yeah, not.
Sir, this is chest X-ray.
This is given as a spotter in the exam. What will you tell?
PA view.
Yeah, louder, mic closer.
Okay. Chest, cardiomegaly.
Yeah.
Left atrial spleen. The left atrial straightening is there, sir.
Yeah, just find out. I'll just see. When you closely watch, you can see the sternal wires or opacities are seen. Only with clinical clues, you may be able to find out those things. You can see the mitral opaque valve here, the residual features of mitral stenosis, the pulmonary plethora, pulmonary edema. So Patient had a sternotomy, prosthetic mitral valve. He has got, you can see the splaying of carina, elevation of left main bronchus because of the then double density of the right border of the heart. All those things are features. This is a patient with a post mitral valve replacement showing residual features of mitral stenosis with the prosthetic mitral valve and sternal wires. So next, can you just compare these two films? So clues are there in arrows. You can see the just make a comment upon the upper lung shadows in the apices.
In the first X-ray, there is an opacity in the right upper lobe, right apex.
Yeah, both are in the right apex.
Right apex, and
this is likely to be a mass lesion. This is likely to be a fungal ball because of
cavitary lesion.
Cavitary lesions. I am not going to details. Time is already over. So flail chest with subcutaneous emphysema, flail and all those things. Mitral stenosis I explained already. So to conclude, when you are given a normal chest radiograph, better to go in a systematic way like this. This is a normal chest radiograph of a male patient, PA view, taken in inspiration. The film is adequate with an adequate exposure and position properly. Trachea is central, soft tissue, bony cage normal, no mediastinal shift, Hilar normal, cardiac silhouette normal, lung shadows clear bilaterally with normal bronchovascular markings, both domes of diaphragm normal, cardiophrenics and costophrenic angles are clear. So this much descriptions are there for this X-ray. This is a normal. This much, at least some 50% of this you are expected to tell in exams. So with this I just conclude my session. Thank you, and thank you for the good participation of the postgraduates from different institutions. Thank you, ISA, for giving the chance again.